Hello, everybody. Welcome to Global Response to COVID-19 webinar, session number 4. It's a pleasure to have specialists from around the globe connected, discussing the management of this disease. This webinar is sponsored by the Panamerican Trauma Society, by the American Association of Surgery of Trauma, the WCTC International Relations Committee, the World Coalition for Trauma Care, and supported by the University of Miami and the Virginia Commonwealth University. I would like to say welcome to everybody. And I'm going to ask Dr. Michel Aboutanos, representing the WCTC, American Association for Surgery of Trauma, International Relations Committee, to introduce the panelists. And afterwards, Dr. Coimbra, representing the World Coalition for Trauma Care, to welcome all the trauma societies from around the globe that are joining this webinar. Dr. Aboutanos, Dr. Coimbra, please.
Thank you, Antonio, and welcome everybody. So these are esteemed panelists. We have Dr. Luca Fumagalli, who is a staff surgeon at Alessandro Manzoni Hospital in the Department of Robotic and Emergency Surgery in Lecco, Italy. We also have again with us Dr. Mauro Zago, again also from Italy. He's a director of the General and Emergency Surgery Division in the Robotic and Emergency Surgery Department, again from Manzoni Hospital in Lecco, Italy. We also have today with us Dr. Alan Guo, who's Professor of Surgery at Sonny Jacobs School of Medicine and Biomedical Sciences in Buffalo, New York. We have Dr. Ali Jafarian, who is the founding chief of the Division of Hepatopancreatic Biliary and Liver Transplantation at the Imam Khomeini Hospital Complex in Tehran, in Iran, and is also the professor in the Department of General Surgery at the School of Medicine at the Tehran University of Medical Sciences. And we also have Dr. Hayato Kurihara also with us again. He's the head of the Emergency Surgery and Trauma Section Department of Surgery in Marttos University in Italy. And I believe, I'm not sure that Scalea is going to be joining us, but if he does, that's Scalea is Executive Director of the Panamerican Trauma Society and a physician in chief at the Adam Cowley Shock Trauma Center for the University of Maryland Medical System. And I will introduce Dr. Kurihara, that needs no introduction. He's the founder and executive director of the World Coalition for Trauma Care, surgeon-in-chief at the Riverside University Health System Medical Center, and professor of surgery at Loma Linda University School of Medicine. So welcome everybody, and we'll have Dr. Coimbra now welcome all the international societies as well.
Thank you very much. On behalf of the World Coalition for Trauma Care, I would like to welcome all the international societies that are participating in this webinar, and thank Antonio and the University of Miami and Michael and VCU for hosting. This is a tremendous achievement where we can bring people from all over the world together. And on behalf of all the societies represented here, I welcome you all, and I hope the sharing experiences here will help us manage the COVID patients that are yet to come to our hospitals.
Thank you, Dr. Coimbra. As you can see, the three main societies, Panamerican Trauma Society, American Association for Surgery of Trauma, and World Coalition for Trauma Care, have all their affiliated societies here, and have physicians from all the continents join this webinar and participating in a collaborative way. That is a very nice collaboration. Thank you. Now I would like to introduce Dr. Rafael Barrera. Dr. Rafael Barrera is the Director of Surgical Intensive Care Unit and Director of Global Health Surgery at the Long Island Jewish Medical Center. So he has been facing a huge response to the COVID-19 in his unit. And he's having a lot of, we're going to share us a lot of information, about a lot of knowledge about what's happening over there. Dr. Barrera, thank you for answering our invitation to be here. We are looking forward to have a presentation. After that, we're going to have 2 more presentations and question and answers. Dr. Barrera, please.
Yeah, thank you very much for the introduction. Okay. I just want to remind everybody that all the meetings of all administration probably is ineffective in this fight against the in this crisis. The meetings should be more educational than anything. So if you are in the loop of the interminable meetings that we have, basically 5 or 6 a day, please, always think it's about the patients. So this is Northwell Health. We have 21 hospitals in the New York area, and my hospital is right on the border of New York City and Long Island. So we are getting hit from New York City and Long Island. There's 21 hospitals right now, of which there's close to 700 or 1,000 ventilator in use in our health system. My hospital has 1,000 beds, including children's and psychiatric units. And you'll see further, we are over 700 patients admitted with COVID right now. This is the New York State cases. A couple of days ago, 53,000, that went higher. And these are the number of deaths. As you can see, the curve still has not plateaued, which is what we are trying to do. This is by county. This is the 2 counties that are next to New York City, right in, so you can get an idea. My hospital is in Long Island, but my office is in New York City. So the line that divides it is very indivisible. And that's why we're getting hit by both New York City and the counties here. And these are the deaths of the counties. As you can see, the slope is still very steep. And Suffolk and Nassau counties are the counties where the rest of the hospitals are, and because they are smaller, we're getting transfers from these hospitals continuously for them to try to basically survive the impact of too many patients that are being sent to those facilities. This is deaths in Nassau and Suffolk County. As you can see, the curve is still very steep, and we're waiting, hopefully at the end of the week, that we will see a plateau on the number of cases. The red line is the Northwell cases, the black line are the New York State deaths, and the green line is New York State cases. As you can see, our lines are very similar in between New York cases and our Northwell hospitals, and we are basically taking care of 20% of the cases that appear in New York City. So right now, the system has not been overwhelmed. We have resources, but if this trend continues, we'll have to start being very inventive. These are our laboratory response. As you can see, the curve is going up, but we have learned over the last 3 weeks how to respond, and our response time now has decreased from 12 hours to 8 hours for the test especially. We are testing everybody in the ER with symptoms, any healthcare workers that have been in contact with any COVID patient and think that person has any symptoms, and the end is getting bigger and bigger in New York City. This is data from yesterday from my hospital. We had a total patient encounters of over 1,500, a total positive cases over 2,000. As you can see, the current inpatient census is 711 cases, and we discharged 600 patients yesterday. The curve seems to be plateauing. This, where I'm showing you is the daily LIJ COVID-19 patient encounters. The orange is the treated and released, and the ones that are admitted. We're still admitting more patients that we are releasing. The patients that we are releasing, as you well know, are patients with do not meet criteria, but have to be quarantined, have to be followed by somebody from LIJ. We have in Northwell a very robust 911 system where the patients can call us and we can give advice to those patients. These are the admissions and discharges from today. As you can see, the daily admitted patients are starting to go down and the discharges are starting to go up. So we think hopefully with these parameters that we are doing better. And of course, this is the discharges and expirations. We're still going up both. This is volume from yesterday also, the daily LIJ admitted volume. The volume is starting to go down. We hope this trend will continue. This is treat and release in the ER also going down, less symptoms, and of course the time for results is less and less because we are becoming very proficient in the labs. This plot is very interesting. The blue line is the medical rapid responses. As you know, if a patient is in trouble, we trigger the rapid response. It has increased dramatically. We usually have 100 rapid responses a month. Now we are up to 25 to 30 rapid responses a day, and the orange is the anesthesia. Every time we call anesthesia, this patient is intubated. The good news here is that the trend in the last couple of days has decreased in the number of rapid responses and the number of anesthesia needed intubation. We still have a large number of patients in the hospital, but the rapid responses are getting less, we hope. This is our medium group of the patients. The bulk of the patients here, 40%, have basically no symptoms, 18 to 44, but these patients here, the 65 and over, are 23%. This is the patients that get into trouble. And then the disparity in care, if you want to show it like that, in Bronx and Brooklyn, is where we're seeing problems with in the African-American population who are diabetic, hypertensive, and obese. Those patients are higher risk and they do poorly in this crisis. This is basically patients with underlying condition, as you well know, will do worse. So the majority of patients that we are admitting, 75 and over, have underlying conditions, and the rest are pending. So I think this is very important. As you well know, diabetics, hypertensive, obese patients will do poorly if they go into respiratory failure. So this is as of today. We have 711 patients in-house, 152 ventilators in use. We usually have a maximum of 50 ICU beds, of which 30 are on ventilators. So I just want to go through what happens with a patient that arrives to LIJ. They were seen in the ER. The ER evaluates these patients and decides to admit. Who gets admitted? As you well know, the patients that are hypoxemic and have some symptoms or at risk. Those patients will go through this algorithm. We're going to minimize fluids. We're going to give early pressors if necessary, and hopefully have oxygenation of 90%. What we were doing to get the oxygenation of 90%, we were putting the patients on non-rim breathers and nasal cannulas. So that was very effective to decrease the amount of patients that will get intubated. If the patient requires this nasal mask and the ventimask and the nasal cannula, and they start doing poorly, we prone them early. I don't know if anybody else is doing, but of the 700 patients, 40% of the patients without being intubation are proned. At admission, they get all these labs, CBC, the coag, the dimer, CRP, ferritin, the ABG and lactate, troponins, and the T cell subset. And then, of course, the hydroxychloroquine. We're not doing azithromycin anymore in our hospital. Azithromycin is out. Everybody gets DVT prophylaxis and Pepsis. We measure also ferritin, CRP, and the D-dimers. Steroids, everybody that does poorly on the floor before being admitted to the ICU will get steroids. So the Metro 1.5 to 2 grams a day. All right. This is new. Before we weren't doing this. We were doing this only for the patients that were doing poorly in the ICU. And then, of course, you get the options to get the anakinra, to get the interleukin 6, interleukin 1, whatever protocol they have been sorted out to do, we do this. And then, of course, in non-rim breather, intubation. We do not put anybody on non-invasive ventilation. If they do poorly, we go directly to intubation. Therefore, that's why we have 152 ventilators in use. All of the ventilators in use, of course, are monitored and have a team of people that have been trained for critical care. We had in our hospital, we have 25 PAs that do critical care, the physician assistants that do critical care, that have been very important in taking care of these patients. Of course, if after intubation the D-dimer is high and the patient doesn't do well, the line started to clot, we start heparin IV. That's still under discussion what numbers will trigger this. So this is the baseline when we admit the patients to the floor. You know, they get an EKG, follow the QTC because of all these meds, and then we separate them with low risk and high risk. And we follow this protocol the best we can. And of course, you know, we have to give the magnesium, we have to get the EKG. If anybody has any problems, cardiac problems, because as you know, with COVID-19, there's cardiomyopathy associated with it. And so we have to consider this from the floor. What we have done also is, this is the lobby of the hospital. This lobby of the hospital have all the COVID-19 patients that are under observations for 24 hours. And this section here is the surgical part of the patients that are COVID negative and need or will require a surgical evaluation. So this is the teaching center and this is the lobby. So all the space is being utilized for this crisis. What we have done to solve the issue of how to take care of close to 200 patients is we follow the SCCM model of deployment in MCIs. So basically, we have different pods of one intensivist with 3 teams of non-critical care intensivist surgeons. And every non-intensivist team of surgeons takes care of 12 patients. And they report or are supervised by a critical care physician. So with this model, we can go up to 200 patients that are ventilated at any time. This has been very good, very well received by the surgeons. This is our first team of surgeons. They're all pediatric trauma surgeons. You probably recognize some of them. And they are in charge of right now 2 units of critical care patients on ventilators. They do rounds like usual. They have their PAs, they have their residents, and they report to us, or they ask us some questions, and we help them. So this has been very, very positive in this crisis, and the morale has remained high because everybody is helping. That's this model. If you haven't seen it from SCCM, I urge you to follow, because if you have 200 or 300% more of your capability of critical care intensivist, it's very simple to follow, and the only thing you need is good direction. The other thing that we managed to do in the last week is surgeries. So who gets surgery? We have an algorithm. Is this operation emergent or urgent, right? Do we postpone the procedure? Yes, no. Is the patient positive or negative? And has he been tested? So this is a very simple algorithm to see if the patient actually needs an operation. If the patient is yes, if the patient has a surgical problem, can we manage this as an outpatient with only antibiotics? These are the appendices, right? And if he doesn't need and he's positive, you need to have full PPE for everybody in the OR. And then you go down the other pathway, and if the patient is negative, yes, no. If it's yes, PPE. Everybody has to be aware of the patient's PPE. And if the patient is negative, usual precautions. If the patient is positive, can you delay this question? Can you delay the surgery, or you have to use full PPE? Which, after a week of taking care of these patients, the PPE becomes a part of you. The other thing that we also did, which is very important, especially for the residents, for the floors taking care, is palliative care algorithm. At the end, who needs an ethics consult, who needs a palliative consult to decide and speak to the family about end-of-life decisions. This algorithm came in very handy in a lot of patients, especially from the nursing homes. The nursing home patients are at high risk, and in normal circumstances, a discussion of palliative care and ethics is probably not indicated. In these conditions, in a lot of patients, we triggered the ethics and palliative care consults a lot earlier, and it has been very beneficial for the well-being of the house staff, especially the chief residents of medicine who are on the floors taking care of these patients, and we are helping them, and that has been very positive. And of course, we know this. We all know this paper. This is true in our patients of survivors. If the D-dimer is high and keeps on climbing, the patients do poorly. And of course, IL-6 and ferritin, very important to follow. And this is what we're looking at right now, because we hope by the end of May, we will be at the tail end of the first wave, but then we'll have the second wave, the impact of resources and restrictions. What about our chronic patients? And then we will be left with all the problems of stress of our staff. I was in a meeting today about autopsies, of the few autopsies we have done on these patients. And up to now, the pathologists have not agreed on what the patterns of the pathology shows. In the lungs, basically, they're describing a pattern of no pattern. And it is basically, there's some thrombosis, some inflammation. The upper airways don't have that much debris, but the lungs seem inflamed, but not a classic ARDS pattern. So therefore, the question will be, should we ventilate these patients like classic ARDS? Our answer right now is yes. We're doing PEEPs up to 18. We prone them early with PF ratio of 150 and in the AC mode. We don't use PRVC, we don't use APRV, we just use AC and, following the peak air pressures, following the mean air pressures and the plateau pressures. The other question that I was asked, what about trachs? We will not trach anybody. So they remain on the mechanical ventilation. Everybody's getting steroids. We're prone in earlier. AC is the mode of ventilation and no trachs. And what we're seeing to finalize this is our African-American population who are diabetic, hypertensive, and obese. We are seeing that they have worse complications. Most of our patients have neuromuscular blockade. We had some problems with Nimbex last week because of the usage. We went to rocuronium. It seemed to be well. What we have noticed from the neurological point of view, and if hopefully there's a neurologist in the panel, there's a delay in the patients coming back to normal. We're describing this as the COVID gaze. It seems that the patients don't wake up as the rest of the patients, and it takes them a long time to recover their senses. They can follow commands, but they're not totally intact. So we think it's either some sort of low-grade encephalitis, cerebral edema, or other. We haven't discovered this yet. The number of patients that we have extubated is a lot, and we send them to the floor because we're still on the first wave of getting new patients on the vent. I think with this, I went through everything. Are there any questions?
So thank you, Dr. Barrera. So we're going to have the other presentation, then we're going to have other questions at the end with all the panelists, okay? So Dr. Aboutanos, would like to introduce the next speakers, please? Now, hello. Dr. Aboutanos is going to introduce. Yes.
Yeah, so I think I've already introduced Dr. Mauro, Zago, and we have also Dr. Fumagalli, both of them from Manzoni Hospital and the Robotic and Emergency Surgery Department, and who will be doing a short presentation.
So thank you very much. Behind me, there is Dr. Fumagalli, who really is the scientist, the co-workers, the colleague, and the leader of the group that tried to get some good information and useful information about what happened in our hospital. And I leave him the mic. Let me share with you the presentation immediately, and then I leave to Dr. Fumagalli the right to tell you what. Is it okay now?
Yes.
Mauro, c'è qualcuno che ha un altro device acceso?
Subito.
Go ahead, Dr. Zago.
Good afternoon. Thank you very much. This is a brief analysis of our first wave of patients with COVID who reached our hospital. Obviously, our numbers are ridiculous in comparison with yours, but let's say. We have in 2 weeks 500 patients to our emergency department, and out of these 500, 200 were suspected for COVID, and we then had in ward 159 pneumonia. Those with positive swab were 107, and non-swab negative were 52. Comorbidities and age are quite similar for the two groups. We took the two groups together because mortality is non-COVID. Patient was not so low. It's 15% comparison with 23% in COVID patients. So we analyzed both populations. According to SARS criteria of the WHO, that is the positive chest raise in dyspnea and fever, contemporary presence of those three symptoms and signs, we have 42 patients in a non-COVID group, and quite half of patients with COVID who display at the beginning, at the starting time, this kind of characteristic. At 4 weeks, the patient discharge were quite close to 80. 20 patients still in ward, and you see at the number 2, 15 patients within the intensive care unit, intubated and mechanically ventilated, 15 patients with insane non-invasive ventilation, and a group of death patient, that is, you see the number 7, patient who arrived agonic in emergency department, and a large group of 16 patients who were treated but not eligible, were considered not eligible to further step to higher intensive treatment, that is mechanical ventilation. So dividing the population in non-intensive or intensive respiration support, we have 16% of non-COVID versus 36% of COVID patient. Dividing by characteristic and comorbidity index, we use the age-adjusted Charlson, which is very, very easy and very feasible. You see that the blue box are the surviving alive patient, and the orange box are the dead patient. You see that quite the larger part of dead patient has very increased high comorbidity index. So older and with larger with a lot of comorbidities, except the intubated, the mechanically ventilated group, which is close to the life, and you see that there are patients younger and without comorbidities. According to the analysis of the biochemical characteristic, we found that COVID patient has display at baseline, that is at presentation in emergency room, absolute eosinopenia, that is quite very unusual and infrequent, and also infrequent for viral disease, and increased C-reactive protein. By analyzing biologistic regression, the death-associated factor evaluated at 4 weeks later, we have the criteria for clinical SARS, the Charlson, eosinophil count, low, that is 0, and C-reactive protein above 7. The area under curve is quite good for predicting the death in this patient. We then analyzed a COVID-only patient in order to find the factor useful for discharge of patient, and we found that those the same characteristics are obviously the reverse of the characteristic are those for inversely associated with discharge, and also in this case the area under curve of this model is quite good. Just a look to the ICU. We have now 77 patients. The median age is 64, and 75% are under mechanical ventilation. The death rate is 27%. The venous thrombolism is quite high, according to the fact that all patients are treated with prophylactic heparin. And we count 13% of all patients, and 70% of alive patients. Thank you very much.
So it was only a presentation of data, and I think that we were surprised, let me say, is that eosinopenia from one side and PCR, so and the score for simple criteria could mark a patient since the beginning at prognostic factors. So we can identify, or at least check one patient as a possible patient with possible worse evolution and needing for intensive care unit. And from the opposite side, we can find some data that can enhance our confidence in discharge patients. This is only a sample, but probably over large numbers, we could find very interesting this data. Thank you very much.
Dr. Zago, thank you very much for your presentation, our group, great data. Let's go now for the last presenter for today. Then I'm going to have a great session of questions and answers. So I'd like to introduce our friends, the famous Dr. Hayato Kurihara. He has been here for 5 weeks already connecting to us. And the first week was not good. Then but we learned a lot in Miami how to do preparation here. And then after the second week, we started connecting through the Panamerican Trauma Society, all these panelists. So Dr. Kurihara from Milan University of Milan and Humanitas Hospital, please give your update about situation in Lombardy and lessons learned, and what's your, how do you think are going to be the next few weeks in Italy, please?
Okay, thank you, Antonio. It's going to be a very short presentation because I think that the discussion is always more important and sometimes it's more important than presentation. It's just a very brief update. And as you can see, this is the general number. This is the last update from our government, and it is updated yesterday. As you can see now, we have been reaching almost 127,000 cases of COVID-19 patients. As you can see, unfortunately, more than 13,000 are healthcare workers. So doctors and nurses got infected, and unfortunately, already about I think 70 doctors in our country already died with the COVID infection. So, and the median age of cases is 62%. As you know, most of the population is they have a very mild symptoms, very few symptoms. 8.5% are totally asymptomatic, while we have a 20% of severe cases and 2.7% are really bad. And what is quite interesting is that in the time frame, in the age frame of from 50 to 59 years old, we still have quite high mortality. I think that 2.4, around about 3% of these patients that die between 50 and 59 years old is probably too much. And this is something that we have a lot of concerns. As you know, Italy underwent a total lockdown all over the country a few weeks ago. So we were quite anxious to see the first results of the lockdown, and I would like to share you the actually present situation from Italy. This is Dr. Paolo Spada, who is one of our vascular surgeons, that started to compare our data with the data from the Chinese experience. And every day he's looking at the official results from our government, and he developed his graphs and statistics. So I'm very grateful to him. He started to publish as a personal perspective of his Facebook account. They're really very interesting because we have seen that also in the past weeks, his numbers were really quite detailed. And this is his estimation. As you can see, we have a total, quite huge number of patients that are doing good and totally healed. But we still have a growing curve regarding death. But as you can see from the purple line, we are seeing the first effects, the real effects of the lockdown. So we really hope that at the end of April, we can overcome the surge capacity that really stressed our health system. So we expect that at the end of April, we will be able to manage in an easier way these critical patients. Okay, sorry. So this is what we were waiting for in the past weeks. For the very first time, now we are seeing for the very first time a reduction of the need of ICU bed. So probably that means that we probably reached our peak. So for the very first time, at least in my hospital, the number of discharged patients is the same number of patients that we are admitting, especially in ICU. So we are starting to breathe a little bit more. And at least in my hospital, this is what we decided to do. We just decided to start the construction of a new COVID hospital that will be totally dedicated to COVID patients. So it's going to be an emergency department, an ICU beds, medical ward, OR, CAT scan, and we hope to finish this hospital within June, because we have to get prepared for next autumn. And what we will have to do now is that we have to start to plan and schedule surgery, mainly surgical oncology. So we design a pathway that is under validation, and we hope within a week to start to operate on more complex cancer surgery. Actually, the only cancer surgery that we are dealing with is some very few colorectal cases, and of course breast surgery, because this has no impact of hospital admission. So these are the next goals that we are facing with, and maybe I will can I update you in the next weeks regarding this issue.
Dr. Kurihara, thank you very much for your presentation again. It's good to see you went through all the phases and already thinking about the recovery, about thinking about next phase and doing elective surgery again. I'm going to open the time. We're going to have a strong and solid half an hour of questions and answers. I'm going to start asking Dr. Barrera. Dr. Barrera, in your presentation, you said that you start proning the patients very early, even before intubation. There's a lot of discussion in many countries when to start the hydroxychloroquine that you said that you use. You wait the patient to be in the intensive care unit, you wait the patient to be intubated. At what point do you start the hydroxychloroquine on your patients? So, or at what point you start to really treat the patient with all these antiviral drugs or any therapy that has been used to help in this situation? Please let him know what is the time, the point that you start treating these patients.
We start treating them at admission with the COVID positive test first, or if high suspicion. So basically everybody is on the hydrochloroquine, the antimalarial drug. According to our ID service, infectious disease service, we stopped using the azithromycin. They don't feel that it adds anything much for the care of the patients. And it, as you all know, it will increase the QTC. And because most of these patients are sick and they're not on monitors and they need EKGs daily, they stop the azithromycin. That's the new thinking. So the answer is we treat as soon as a patient arrives in the hospital with or without a COVID positive. Most will be COVID positive, especially the ones with comorbidities. We are proning them early. As soon as they increase the oxygen demand, saturation is less than 92% and you're going up in the oxygen, we prone them awake. And it seems to be working. Right now, I just got the numbers. We have 709 patients on the floor and 145 patients on vents. So we managed to take 10 patients off the vents last night.
How is your mortality? What's your mortality?
I'll tell you right now, I have the numbers right here because I knew you guys were going to ask me this. We have a total expiration of 144 patients up to now, 15 in the last 24 hours. We have treated and released 597 patients COVID positive and with a total discharge of 633 in the last week. 152 total vents in use, and we have 20 vents still available and coming more. So we can, as I told you, we can actually go up to 200 critical care beds if needed, with physicians, with complete teams to take care of the patient, if we activate the non-critical care surgeons to take care of these patients.
Thank you very much. This is very important because, again, your protocol, you are able to have you are some weeks behind Italy. So in Italy, yes, they start to change protocols to test things in the middle of the surgery. So I think here in the United States and in other places that are even behind us, like in South America, you have other options to treat. Dr. Aboutanos, you have a lot of good questions. So can you choose the first one?
Yeah,
and make to the panelists, please?
Yeah, thanks, Antonio. Actually, I want to just compare a little bit because there is continual controversy with regard to the proning question that you've asked. I wanted to know if Dr. Jafarian and if our colleagues from Italy, what's their experience on proning. As remember last week, the experience from Italy on proning was that it was kind of not necessarily positive. And so now that we have the New York experience, at least for one part, I'm going to see if both Dr. Jafarian and Dr. Guo from the panel, also with our colleagues from Italy, all feel about proning, if we could just get that across the board. So can we start with Dr. Jafarian? What's your experience been on proning?
Thank you, Dr. Aboutanos, for the question. As we talked last week also, and our colleague from Italy talked about that, we do not have any proning experience in our patients. Our ICU intensivists more likely do the NIV and start it very rapidly. If the patient's oxygenation is going to be down, they transfer to an intermediate care ward just before the ICU. And if the patient is a high-risk one, they are transferred to ICU. Totally, our intubation rate in ICU cases is like 50%. So 50% of the patients in the ICU are not intubated, and most of them are on NIV. So maybe the prone situation need more experiences or more personnel. I don't know. Maybe our colleagues talk about that. And if there is any dedicated patient bed or any other instruments to do the proning. So that's why my colleagues here are not using proning position for the patients.
I see. Dr. Zago, what's your experience? Positive, negative?
No, to be honest, as you know, I am not an intensivist, so, but I contributed, and a large part, quite all surgeons in our unit are cooperating in COVID wards, and the policy of our intensivist is is in favor of an extensive use of pronation. So not only intubated patient, but also patient in CPAP, so in non-invasive ventilation, and even patients without non-invasive ventilation are invited to prone themselves in order to improve their exchanges, ventilatory exchanges, and patient is a kind of an anecdote, but anyway, it happens that some patient with non-invasive ventilation, when they perceive the improvement they can get proning, they prone themselves. So they ask for support for not being so distressed by the prone position with the cask, but they are trying to pronate themselves.
I agree with Dr. Zago. I'm sorry. In Buffalo, we have all hospitals combined. We have about 100 intubated patient, COVID patient in ICU. We follow the surviving septic campaign guideline. We almost every patient. In addition, we also prone the non-intubated patient. The problem with the proning the non-intubated patient that they cannot lay down like that for like 14 to 16 hours as recommended by the guideline. So the thing is that they need to turn back, they need to do some position change. The result, we don't know yet, but for preliminary result, looks like it's pretty good.
Great, thank you. Let me go. The next question has been asked is with regard to the non-conventional ventilation, the use of APRV. As you know, across the country, there's been a question with regards to high PEEP versus low PEEP. This is not truly ARDS-like. So I'd like to see what Dr. Barrera's experience is. Are they using high PEEP versus low PEEP? Are they using non-conventional ventilation? And let's start with Dr. Barrera on that.
Yes, we are not using APRV for the patients. The problem that we're finding is that they're very difficult to ventilate because of the synchrony with the vent. So the majority of the patients, I don't have the percentages, but in my opinion, over 40% of the patients are paralyzed. Mm-hmm. So that's what we're just using AC. With high PEEP, the surgical department, we basically are stopping at PEEP of 18 and proning. The medicine department, which is a little bit more aggressive, are using higher PEEPs to 24. Nobody has a PEEP of 30. For the old, for the old timers like me, a PEEP of 30, 35 was okay, but not anymore.
Right.
So we stop at a PEEP 18, see the PF ratio. If it's less than 150, we prone the patients immediately. And we follow the guidelines of mean air pressure, plateau pressures, and everything. As soon as we can, we start decreasing the PEEP and the FiO2. So we stop weaning the FiO2 at 50% and hope we just leave the PEEP around 10 or 12 and see how the patients do.
There was one question that came in and follow is with regard to the paralysis. how soon they're paralyzed, or how long have you seen your patient being paralyzed on the protocol that you have?
We tend to paralyze the patients very early. And I think this is secondary to two things. Because of the number of patients and the ratio of nursing critical care patients. And we don't have enough time to get the optimal sedation, so we tend to paralyze earlier. We tend to paralyze early because of the nature of the disease, that the synchrony with the event that I told you. And they remain paralyzed a lot longer than we will usually do with a normal pneumonia, neurodifficult patient. In our unit, we seldom paralyze a patient.
Mm-hmm.
So we keep them a couple of days paralyzed, 3 to 5 days, sometimes 7 days.
Yeah. If I can add something,
sure.
I am Mauro Zago. If I can add something, I can say you that there is a concern about paralyzing agents, drugs, and the shortage of drugs. I don't know if your experience too, but in let me say the main central hospital in Milan, they are using pentotal. So the old pentotal, pentotal is I don't remember. Pentotal is a commercial name. Is succinylcholine for paralyzing and for sedating the patient, because there is a shortage of propofol and other drugs due to the so high number and so prolonged time they need to be intubated and paralyzed.
Great, thank you. Antonio, you had additional questions from
yes.
you mentioned?
Yeah, there's a couple of questions about hydroxychloroquine here. So, sample Dr. Lilian Abu, she's the chief ID for University of Jackson Memorial Hospital. Question, I'm going to try to summarize the question. So first, why did you stop using azithromycin? And second, what's the dose that you use for hydroxychloroquine? When do you start? And some question about, did you start this as soon as the patient is admitted, or the patient is ambulatory, did you start ambulatory? Dr. Camilo Ricordi here from Transplant Unit here is asking about prophylaxis by healthcare professionals. There's some groups taking chloroquine prophylaxis to increase the level slowly. So all these questions condense about chloroquine. So indication, contraindication, why did you stop using azithromycin? The doxycycline work also, and about prophylaxis for healthcare professionals. You can summarize this, you, Dr. Barber. All the three presenters, please, you give your opinion about that, please.
So the azithromycin decision was from the ID service. They felt that it wasn't adding anything to the care of these patients. And because everybody was on it, it prolonged the QTC, and they thought the risks were too high. So that I was not on that decision. And, you know, the ID people thought that it was not useful anymore, because most of these patients are either on the antimalarian drug plus the anakinra or the tozi, so that they felt was enough treatment for these patients.
And actually, Dr. Abu make a question about anakinra and tozi. So can you talk a little bit about that, please? A little bit more.
Yeah. So the anakinra, most of our patients are on anakinra, and then we have the trial for the interleukin-6 also, but that's a randomized trial. 80% will get the drug, 20% will not. So I don't know who's getting it or who's not. So basically, most of our patients are on anakinra, steroids, the antimalarial drug, and prone in the hospital with oxygen. So that's, and then 80% of those patients randomized will get the tozi. So I don't know the answers to this. We'll know probably with the number of patients, probably by next month, what worked and what did not.
What about prophylaxis for the healthcare team? So any comment about that?
We are not doing it. I know some hospitals, I think some hospitals in New York State are doing it. And some anesthesiology groups are doing it also because they're the highest risk for intubation. We are not doing this. We just have very good training for PPs, We do not have any shortages of masks or anything. So our hospital system is very well equipped to receive more patients, and we have all the materials. We have not seen any drug shortages. We had one day where the Nimbex was low, and some patients got rocuronium, but that has not been the case anymore.
The same question for Dr. Hayato Kurihara. So what about these using the convalescent plasma or IVIG? So Dr. Hayato, any comment on when to start the hydroxychloroquine? And if you did any prophylaxis with the healthcare professionals, and you have almost 10% of patients are healthcare professionals, Dr. Kurihara, your comments, please.
Regarding the healthcare professional, yeah, no prophylaxis, and as the others do, we start follicking quite early. And we stop the azithromycin too.
Dr. Barrera, I have a question for you, talking about steroid use. Do you use steroid for the purpose of septic shock or for the respiratory, the hypoxemia?
We use it basically for both, but I think most important for the inflammatory storm. These patients, as you know, if you take care of enough of them, they get very sick. You see them, they do better, and then have another storm with fever, hypotension, and that's what we are opting. As soon as the patient starts deteriorating, basically have a high fever, desaturating before they come to ICU, we start the steroid, Solomedrol 1.5 to 2 milligrams a day per kilo. So it's a very high dose, and I think it's working. Most of our patients are on steroids, and they get the steroids very early on the floor.
Okay, thank you. Dr. Coimbra, your questions for the presenters, please.
Maybe he's trying to unmute his phone.
Dr. Coimbra. Okay, while you have some difficulties, Dr. Coimbra, Dr. Aboutanos, next questions, please.
Let me ask, but there's one question which also goes into the ethics of this. So this is what for Dr. Barrera and any of the panelists. How do you handle a prone patient that is coding? There is both the mechanics of it and there's also the ethics of it. I'd like to have both answered if possible. Dr. Barrera, I'm going to take that first, please.
Sure. A patient that is prone and codes, basically, the number one thing we do is we don't take them off the ventilator, right? So we have the strict order that nobody gets off the ventilator. And the reason is very simple. If you put the ventilator, the next breath, you get you spread the disease everywhere in the room, and everybody gets the contact. So that's number one. Two, before we prone every patient, we do an assessment of if this patient codes, are we going to code the patient? So they are the sickest patients, usually with comorbidities, and we have a very strong palliative and ethics group that is following these patients closely. And everybody more or less has not a DNR in place, but a conversation with the family. The neurosurgeons have been very handy in this because they are not part of the deployment group. They are taking the information to the patient's family and informing them because there's no family members in the hospital at the present time. So before we code a patient, everybody has a status. If we need to code them, it's just a chemical code with some compressions, no more than 10 minutes, not take them off the vent, and we stop.
Is that the same with the other panelists? Is that doing something similar, Dr. Guo?
Yes, I spoke with my medical intensivist. They are the one who take care of most of the COVID ventilated patient. They have the same thing. We did practice the same thing here in Buffalo. We only do chemical code.
Okay. We go to my next question, which was one question asked with regard to tracheostomies, and a lot of people say no tracheostomies. And Dr. Mauricio Lind posed this question: what happened when 4 weeks come by and the patient is still on the ventilator, do you do a trach then or not? To go, what do you guys do?
We still assess the patient. If the patient needs trach, we will do trach, but we'll make sure that as a surgeon, we are adequately protected with PPEs.
Okay. And Dr. Barrera?
We haven't had any patient before for 4 weeks already, so we don't know where we are. We stand at no trachs at the present time, and probably the decision will be if somebody is on a vent after 4 weeks, it will be a discussion. Hopefully by then he will be COVID negative and treated, and it's just respiratory failure or something, and he will require a trach. But the problem there is going to be placement. You know, traching him is easy basically. The problem will be where do you put this patient and where do you place him afterwards in the respiratory failure unit. So I think what we're going to wait until the 5th week to make that assessment, and hopefully I'll be invited again to give our experience about the trachs in our institution.
Okay, we'll plan on that. How about any experience with doxycycline? Anybody have used it from the panel and any good results with it? Without Dr. Zago or Fumagalli?
Probably not.
We didn't understand very well the question, sorry.
I'm sorry. The use of doxycycline, is that anybody have used it? Has there been any good results?
No, it's not our experience. We have no experience about that.
Okay. The other question, this is coming up, and not just here, also in other sessions, with regard to sedation of the COVID positive patient, and they're very difficult to sedate. Any experience with phenobarbital or barbituric? This is a question from Dr. Hernan Sacoto from Ecuador on the use of phenobarbital. Dr. Barrera, what's you guys' experience with what are you using for sedation of these patients?
All right. So I can tell you our bias was against propofol. So we have not been using propofol in the surgical ICUs and the 50 or 60 patients we're managing. And it's biased because we feel that propofol might have some pro-inflammatory response syndrome and might help clot the lines. We have not had any clotted lines like a lot of institutions have been reporting. We're using Precedex, fentanyl, and Versed.
Okay.
And plus Nimbex, of course.
Okay.
That's our 3 main drugs.
Okay.
Anybody else on the panel?
I'm sorry, I have a comment on the propofol too. Oftentimes, when you do the propofol, you also drop the blood pressure. So we, like Dr. Barrera, use Precedex, Versed, and some other medication, but not propofol.
Okay. There's another logistic question. Many of you have described a large number of ventilated, intubated patients, which puts into the question the need for negative pressure OR rooms and negative pressure ICU rooms. This question came from Dr. Medea. Does everybody have negative pressure room in their OR, or when the surge went up, did you simply just switch to any room and have been forced to kind of use positive pressure room as well? So Dr. Barrera, let me ask you first.
Okay. So when we started, we had 39 negative pressure rooms that were converted. We usually have 6 negative pressure rooms. We converted our close to 30 patient negative rooms. But then when the surge came, that was impossible. So most of our patients are in PACU-like units. So we assume that the whole unit is a COVID unit, and everybody has to have adequate PPE.
Is that the same, Dr. Fumagalli or Dr. Zago or Dr. Kurihara in Italy?
About pain,
about switching from a negative pressure to positive pressure as something that.
Okay, no, we in our hospital, negative pressure rooms were established only in infectious disease unit and in 2 operating rooms. So at the beginning, we tried to put COVID positive patients in effect, obviously in infectious disease unit, but at a certain point, we weren't able to face to the burden of patients. And we are trying to get some filters, mechanical filters, cleaning the rooms that roughly are correspond to great respiratory filters with a positive pressure that can clean in a few minutes. But unfortunately, due to the pandemic, it's not easy to find it, to buy them.
Yep. Okay. I've got a practical question now regarding if a patient presents with a pneumothorax, should the surgeon wear a special N95 mask during the thoracostomy? So,
my answer is yes.
I'll answer.
My answer is yes. We
and
need
not only an
ourselves.
N95 mask. The way we do it is an N95 mask, a regular mask on top, a shield, a hat, a gown, and a second gown.
Okay.
I can add something. Is a trick that our thoracic surgeon, who in this period is in charge for the bronchoscopies and intensive care units assistance, is if you think to pronate a patient, put the drain in the mid-axillary line. Otherwise, the day you have to pronate, you will have in one of the 2 positions a problem in managing the drain. It's very stupid things, but it's practical thing.
Oh, it's excellent. We only think about that afterward. A great suggestion. There was one question with regard to nutrition. How are you feeding these patients? For how long?
It's from Dr. Bayer from Miami. So, enteral nutrition, parenteral nutrition. So, anything special? Any tip to give to us?
All our patients have enteral nutrition. None of our patients have had gastroparesia like every critical care patient. What we do is we ran out of pumps. So we're doing bolus feeds at 20 kilocalories per kilo per day of ideal body weight. And it's been working well. What we do is we feed 3 times a day with the patients that are prone. Basically, they're prone 16 to 18 hours, and the other hours we feed the patients in 3 bolus feeds. And the rest of them, if they're not required to be prone, if there's a pump, for 24 hours. But I think the trick is less volume, and of course, you have to see the protein that you're feeding the patient depending on their renal insufficiency or liver insufficiency. They have it, but 20 kilocalories per kilo per day is what we're using.
Okay. So, Michael, I think we need to wrap up the conference. I'm gonna send 2 final questions to all the 3 panelists, okay? Dr. Carl Schumann asked a question. So, do you have any triage protocol for ventilating patients? Which one should, if you are above your capacity, which one should go, which one should not go, and what time with 3, 4, 5 weeks to reassess, and are you withdrawing care in any of these patients? So last week, Dr. Prodri from Italy said that 2 weeks, 14 days, they reassess the patient to see if there's any prognosis or not. Anyone seeing patient with lupus? And also the last question is from Ecuador, from Dr. Vasquez, Eliane Vasquez. For the 3 centers, after so many weeks in Italy, after learning a lot in New York, so what do you think is working? So what do you think is the therapy that's working now, and when should it be started, okay? So let's start with Italy, then we're gonna have Dr. Barrera at the end. So Dr. Hayato Kurihara, so when to withdraw care, which patient go to the ventilator, and what's working? Dr. Hayato?
Yeah, sorry, I couldn't hear your question.
So when do you stop treating? So at any point, do you draw care and the patient has been in the ICU for 2, 3 weeks, 4 weeks on the ventilator? And second, what's really working? Is the question for Ecuador. Ecuadorians in South America have a lot of problems. What is your opinion is after trying so many things is working in the treatment of the COVID patients?
Yeah, actually, I think there is not a single answer. We have an update with our intensivist every week to understand. We have been observing one thing. First, proning, yes, but it seems that as soon we finish the proning, the patient gets worse again. So sometimes we have the feeling it's just like a cosmesis, as Dr. Totti said last week. What we have seen, I think it was very interesting, the report from Lecco Hospital from Dr. Fumagalli and Dr. Zago regarding the eosinophil count. What we have been observing is that the patient that keep staying with 0 eosinophil, they're really doing bad. And the best results we had as prognostic factor is when the eosinophil count starts to improve, to increase a little bit. Those are the guys that are doing fine in general.
Thank you, Dr. Dr. Zago, please.
We are involved in a trial with tolicizumab, but we don't know. It is too early to say there is an interim analysis. But the first feeling of our infective disease specialist is not so good, and what we implemented in the last 10 days was prophylaxis and high doses of low molecular weight heparin, because we saw a lot. This is not specifically addressed to the disease, but many patients develop thromboembolic complications. We had not so few thromboembolism, thrombopulmonary embolism, even some strokes were admitted to our stroke unit in COVID. So this, in the last week, we had also slightly symptomatic or completely asymptomatic colleagues with low with TVP, deep venous thrombosis, and this is one thing we are discovering and we are addressing very aggressively.
Thank you, Dr. Rafael Barrera.
I think the question for a country like Ecuador with limited resources, the easiest thing will be everybody on Plaquenil, steroids, early proning, AC if they have the vents, and heparin for everybody. And just follow, if there's no availability for all the labs that we're using, just follow the PF ratio and see how the patient's evolved. As soon as the patient has been on the vent for a couple of days and he has a secondary fever, treat for either a ventilator-associated pneumonia or a secondary bacterial pneumonia. And I think that would be the most effective usage of resources in a country from like Ecuador. And by the way, I'm from Quito, so I sort of know how things work there.
Okay. Thank you very much, all the presenters and panelists. Any other comments?
Yeah, I have a comment. In terms of prophylaxis anticoagulation, and I think I have an email in the the international relations of the AAST, I was talking about knowing one of the vascular surgeons from northern Italy who had like 50 autopsy of the COVID positive patient in front, a lot of clot in the lung, in the leg. So I think the question I have to raise two issues. One is that we should do more autopsy, although there's a lot of technical issue and how to protect ourselves. Is it autopsy considered to be a aerosol generating procedure? And what is the hospital regulation policy for autopsy? But from the scientific point of view, we should do more autopsy to find those pathology in order for us to understand the disease. Number two is about the anticoagulation. We all talk about like anticoagulation, but there any scientific evidence? And the question here is how long we're gonna do the anticoagulation? And what if the patient has a contraindication? What do we do?
Dr. Barrera, can I quickly answer that? Or
we have
yes,
a very short
ahead.
comment. For our colleague from Ecuador, we start hydroxychloroquine from the beginning for every patient, and the only antiviral therapy that is used in Iran now it is atazanavir and nothing else routinely. So there were a lot of experiences other than that. After 2 months, they are just my IDE guys and colleagues are using this routinely, and the most important thing is supportive care. Because what we are faced with is not just a viral infection, is the inflammatory storm, and the supportive care help us. We do some tracheostomy if the patient is going well, but not could be off from the ventilator. So they do with full PPE, of course. Thank you.
Thank you. Dr. Barrera?
The autopsy, they're doing the autopsies with full PPEs also. And they consider that the infection is latent, even in the dead person. So that is one thing. We see it right now. We don't agree with the tracheostomies, because it's not only about the surgeons, but placement of that patient with the trach and in an open unit basically. And then you will have everybody taking care of that patient with a tracheostomy will have to have PPE wherever they go. So that might be cumbersome for a lot of countries from the materials management point of view.
Thank you very much. So unfortunately to end, I would like to say that the Panamerican Trauma Society, the American Association for Surgical Trauma, and International Relations Committee, and the World Coalition for Trauma Care, with University of Miami, Virginia Commonwealth University, they're very glad to have this kind of meeting. These professors discussing, interacting with physicians, nurses, and healthcare professionals around the globe. Next week, we're going to focus a lot in treatment. We had a lot of questions about treatment, so we're going to focus about treatment, and looking forward for another good conference next week. So Dr. Aboutanos, Dr. Coimbra need to leave. He left for another meeting, but could you please thank you all our panelists and presenters and talk in the name of all the two societies to everybody attending this webinar, please.
Yeah, I also want to thank everyone, especially for your time. All of your answers and all the questions are extremely important. If any of those questions we have not answered, we will be answering them on the website. If you go to the Panamerican Trauma Society website, the answers will be there. And please also feel free to send questions preemptively before the next session. And we could also prepare our panelists for some of those questions as well. But we want to thank everybody for that time. It seems we always go overboard because this is so needed. And we just, like all of you, we're all in solidarity with this. We're learning from each other. And we all know that there's no answer for everything, but we're all working together. We appreciate all our panelists and our speakers. And thank you so much.
Thank you all. See you everybody next week.